Thank you so much, Jürgen, for that wonderful introduction. And I'd really like to thank the IAS and the conference organizers for inviting me to speak today, and for giving me the rather unenviable task of speaking about eliminating not one, but 3 viral pandemics in 15 minutes. So consequently, my talk is necessarily going to be at a high level and a bit of a whirlwind. So forgive me in advance for what I leave out. But what I really am hoping to do today is to get us to critically think about elimination, to examine some of the key lessons that we've learned from trying to tackle each of the viruses that we're talking about today, and the lessons, how these can inform the critical next steps. These are my disclosures. And before I begin, I think it's important to recognize that we are meeting today on the unceded traditional territory of the Kanekahaka peoples. It's of particular importance, I believe, when addressing elimination of these 3 viruses, which disproportionately impact Indigenous peoples in our country due to the ongoing effects of colonization. We have to listen, and we have much to learn, as Doris Peltier so elegantly expressed earlier in this meeting. So what do we mean by elimination? Eradication, the complete control of an infectious disease, has really only been achieved for one global viral pandemic, and that's smallpox. And that's due to the availability of an effective vaccine and the fact that the virus does not have an animal reservoir. What we're talking about today is elimination of viral hepatitis and HIV. This is the reduction in the incidence of infection and of disease so that it's no longer a public health threat. But importantly, elimination cannot be the goal in itself. Sustained measures will always be required to prevent reemergence of infection. So what are the targets? I'm not going to spend much time in this talk talking about targets, but they're well known to you all. These were set out originally in 2016 as ambitious goals to reduce incidence, to reduce death of both viral hepatitis and HIV. We'll talk about more at the end how we're doing with respect to these targets. Rather, I want to look at what are the key ingredients for elimination. Simple tests that can detect active infection accurately and cheaply, and ideally can be placed in the hands of the people who are at risk so that they can test themselves when and where and how often they wish to. Treatment, ideally one that cures, but must be available at affordable cost. Vaccines, preventative vaccines that are cheap and easy to administer, and or a therapeutic vaccine, particularly for the case of HIV or hepatitis B. And finally, prevention. Prevention must be accessible, it must be safe, and widely available without stigmatization. I'm going to take each of these infections quite quickly and look at where we are along these key ingredients and how they can inform elimination going forward, and talk to some of the challenges that still remain. So clearly with HIV, we have good tests. Self-testing remains a problem, and I was very pleased to see yesterday the announcement from our federal minister about expanding self-testing in this country. This is long, long overdue. It makes it much more easy for us to reach out to vulnerable populations who as of yet remained undiagnosed. We have treatment, as you well know, that is highly effective, simple, and more increasingly available, but treatment for HIV is lifelong, and access to second-line therapies are still an issue in many countries. We know how to prevent HIV, but implementing those measures remains challenging. And finally, the holy grail is to have a cure. All people living with HIV are holding out for this. The science is fascinating, it's exciting, and must go on. But at the moment, the regimens that we're looking at are likely to be complex, and scalability is questionable, and they're certainly going to be quite costly. So what have we taken from HIV that can inform how we address elimination of viral infections? Certainly, treatment prevents infection has got to be the main lesson we have learned. The science is clear. U equals U. We're applying this in HIV, and we're starting to see the benefits that this could have for hepatitis C, for example, at least in modeling, and we're looking for the real-world data. But what about hepatitis B? Have we used this paradigm effectively? I don't think so. we could use it better, perhaps particularly to prevent mother-to-child transmission, and I think we need to re-examine that. HIV has certainly taught us about the value of prevention using biomedical approaches such as PrEP. But the other thing it's taught us is that adherence is critical, and we need to think of ways that we can enhance that. I think the evidence about the value of long-acting therapies is clearly demonstrative of what we need to do to be able to achieve the potential of this approach. Moving to hepatitis B, testing, again, is available, but it's quite complex. The number of primary care physicians who still contact me to understand the differences in the serologic assays is quite impressive. Let alone we need to have DNA testing to diagnose and make treatment decisions. I think it's time to be thinking about how we simplify the management of hepatitis B so that it isn't so disease-based focused, but more in a lens of trying to eliminate this virus. Treatment does exist for people who live with hepatitis B, but again, lifelong therapy is required for most. And the lack of access to tenofovir in many countries, when you don't have HIV co-infection, is quite stunning. Unfortunately, although it does have a tremendous role in reducing the risk of hepatocellular carcinoma, people remain at risk and require lifelong screening. So we really need to work at preventing new infections from occurring in the first place. In this instance, we do have a very effective tool, but there are many implementation gaps, as I'll mention in a moment. And again, cure has been elusive. A lot of research activity in this area recently, which is very exciting, but like HIV, at the moment, this is likely to be difficult to scale. So when we look at hepatitis B, here's the example of where vaccination could be a real effective tool. It's available, cheap, highly effective, and essentially has reduced horizontal transmission in the vast majority of people around the world. However, vertical transmission remains a challenge, and we can really see how we need to do better to scale up hepatitis B birth dose vaccination because of the tremendous impact it could have in preventing deaths and new infections going forward. Triple dose vaccination has increased through the years for hepatitis B, but there are still many regions of the world where too many children remain at risk. And as an example, I think we can see how fragile vaccination programs can be. So when we can come close to achieving our goals, destabilization in a country can rapidly undo all the good work, and suddenly we're in a situation where vulnerability increases. And this has really been the case as a reflection of the COVID pandemic as well, how we've seen how childhood vaccination programs around the world have really been affected. Turning to hepatitis C, testing is obviously available. But here again, we need an RNA test to confirm chronic infection. And this will become more and more important the more people we treat, because once people are treated, they're no longer infectious as they are cured. And the population that is actually chronically infected becomes smaller, they'll become more and more difficult to find. Treatment and cure in this situation is a tremendous advance. But reaching vulnerable populations and expanding beyond specialty centers remains an elusive goal. Unfortunately, we have no vaccine for hepatitis C, and inadequate harm reduction measures for many of the drugs that people use, as Julie Bruneau alluded to very nicely in her plenary earlier this week. Criminalization of drug use clearly is a major barrier to making inroads to eliminating hepatitis C. And the cure still remains far too expensive for a large number of people. So when we look at hepatitis C, here's the paradigm of cure and what could it bring us. There's very safe, effective, short-course antivirals, direct-acting antivirals for as little as 8 to 12 weeks that can achieve greater than 95% cure rates, regardless of genotype, regardless of whether cirrhosis is present, regardless of co-infection with HIV or prior hepatitis C treatment. And treatment can be very simple as giving an antibiotic. I think this lovely, elegant clinical trial by Sunil Solomon published earlier this year showed that we could deliver hepatitis C treatment in low, middle, and high-income countries without doing genotyping, with dispensing the full 3 months of treatment at the outset, no on-treatment visits, and only 2 remote scheduled contacts, and achieve a greater than 95% response rate in people who do not have advanced liver disease. This means that we should be able to move hepatitis C treatment out of specialty centers into communities and primary care practices, and that should allow us to improve the numbers of people treated. Hepatitis C has also very well demonstrated how treatment costs can be reduced and how they must be reduced actually to make progress. The peak spending for hepatitis C drugs occurred in 2015, with over $20 billion spent on these medications, largely in high-income countries. But what we saw is that the pressure of community and activism to bring down prices through generics was rapid and unprecedented, I think, for any other infectious disease that I'm aware of, to the point where now, in countries with high burdens of disease, with aggressive elimination programs such as Egypt, India, the cost for a course of therapy is well under $100. That's not the case in high-income countries. Now, we're still facing treatment costs, at least at the list price, in the $40,000 to $60,000 range. What if we could reduce those costs and use that money to increase testing and other services for people living with HIV to get them on treatment? Treatment is clearly the key to eliminating hepatitis C, but the treatment rates required are very high. And this is just some modeling work that was done by Charlotte Laniès, a PhD student working with me on the people who use drugs in Montreal. And what we showed is that we can reach elimination targets. We do need to scale treatment up to over 100 treatments per 100 person years. This little blip here is the impact of COVID pandemic. But what's more important, I think, is that once we achieve elimination, we really need to keep measures to reduce it reemerging, and harm reduction there is key to maintaining all our gains. So with the cure, do we still need a vaccine? I think this was a question that we recently participated in a really interesting workshop held in Toronto, led by Jordan Feld. A vaccine is clearly needed to eliminate hepatitis C. The number of acute incident infections is going to surpass the number of people treated. In fact, treatment is essential, but what you just do is turn somebody who was previously infected to someone who is now susceptible. So if there are not countermeasures in place, such as through harm reduction and vaccination, we're just going to have an ongoing cycle of recurrent infection. Unfortunately, our progress with respect to hepatitis C vaccination has been slow and difficult, and we maybe need to look at novel ways to approach it. So how are we doing? These are my little indicators, nobody else's. You can see by the recent release of these figures, if we stay on track to the dotted lines, we're not doing so well. What does this mean effectively? That only 43% of people receive a birth dose vaccination, and there's still 890,000 deaths from hepatitis B per year. Only 21% of people are diagnosed with hepatitis C, and only 62% of them treated, and 297,000 deaths per year. HIV, we know we still have room to go. It also depends on where you are and who you are. So whether you're living in certain parts of Eastern Europe or Middle East, in our country, where indigenous peoples are disproportionately not accessing treatment, in the United States, where PrEP coverage is clearly disproportionately in the white group. So are we setting unrealistic goals in public health? There are some positives, I think, from doing this. We can definitely motivate action, mobilize partners, attract funding, and focus our efforts. But if we focus too much on these goals and fail to reach them, we can undermine the field's credibility. One way to use the promise of these goals is to use the unrealistic nature of the goals through realistic, precise, and actionable sub-goals that follow shortly thereafter. But then we can have a global pandemic interrupt all our good work. So now the question is, can we leverage those hundreds of billions of dollars spent to tackle COVID-19 to strengthen our surveillance health systems and enhance HIV and viral hepatitis C services? It's increasingly important as we realize the linkage of all these new infections that will come on their heels. We need to think creatively about how to integrate all these services. So while elimination tools and targets are necessary, they're clearly not sufficient. These are the other things that we need to have to address our goals: commitment, sustained investment, reduced costs, and equitable access, and certainly, in my view, engagement with community so that we reach our ends. I'm almost through. I just want to conclude with one model that we're working on here in Montreal for the last 2 years. At the center of this model, called Métropole sans FC, are the key populations that are most affected by hepatitis C. We recognize the intersectionality between these groups and how they can inform and help us co-design interventions to increase testing, prevention, and treatment. We will implement them and determine the conditions for sustainability, and our aim is to develop a roadmap for Montreal to become the first city in North America to eliminate hepatitis C and provide a path forward for other cities so that they can do similar things, not only for hepatitis C, but with other infections. And this places these viruses at the center as a hook to bring people in, but recognizing that we need to be addressing all these aspects of care and determinants of health that really affect people's vulnerability to infection. So in closing, I'll leave you with this quote by a 16-year-old. "We have come far, but I'm afraid the first 90, 90, 90 was the easy part, and it wasn't easy. The next 10, 10, 10 is where the hard work really begins. Not only do we need to re-engage, follow the science, recommit, and increase the funding, but even more, in my opinion, we need to rethink how we go about doing everything we do. Another wise person once said, 'Insanity is doing the same thing over and over and over and expecting the same results.' I look forward to working with many of you in pushing the transformative and systematic change that will be required to reach triple elimination. And thank you for your attention today.